the test that, it helps in determining the lung volumes and capacities. It's based on Boyle's law. So basically what happens is here the patient is made to sit in an airtight container and he has to breathe against a closed shutter. So he will have a mouthpiece and then he has to breathe in that. And then the change in the pressure during the respiration in the closed container is what is measured. So this helps in measuring all those volumes that we spoke about: the tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. So all of these readings are measured in a body plethysmography. So basically what happens is in an obstructive defect, the total lung capacity gets increased because of a lot of air remains in the lungs during expiration, because the patient is not able to push out the air during respiration. The lung capacity is increasing because the expiration, the residual volume is increasing. In a restrictive disease, the total lung capacity is obviously reduced. So same thing happens in the residual volume also. So in an obstructive defect, it increases because of the incomplete emptying of lungs. So that's what happens. So this is what it looks like, and we have a curve also that is measured. So based on the time, a patient's vital capacity and then inspiration and all of those things are measured. There's also something called as a gas diffusion study. So this is basically done in two ways. It looks at the alveolar integrity. So open circuit method using a nitrogen washout, closed circuit method using a helium dilution. So these are a little more sophisticated studies, not a general practice based studies, but we can refer patients for these things if at all it is required. So in a nitrogen washout, what happens is a patient breathes out 100% oxygen and nitrogen washed out of the lungs gets measured. In a helium dilution method, again, the volume and concentration of helium is added and diluted in proportion to the size of the lung volume. So basically, this looks at the diffusion of gases across membranes and measures that. So it looks at the diffusion capacity, basically, like I said, looks at the integrity of the alveolar blood membrane. So this basically, we also have the single breath technique, which is a DLCO that is measured. So why this is important is in diseases like pulmonary fibrosis, emphysema, or if a patient has pulmonary emboli, or if there's a pneumonectomy that has been done, then this diffusion lung capacity of carbon monoxide gets reduced. So that is what this is used for. Basically looks at the integrity and size of the alveolar blood membrane rather than a lung volume or a lung capacity. So we also have the cardiopulmonary exercise testing. Like I said, it's similar to a treadmill test, but rather than measuring a heart parameter like an ECG, it measures variables like oxygen uptake, heart rate, cardiac output, and all those things. So it helps us to identify the reduced exercise tolerance due to ventilatory abnormalities and chronic lung disease. So basically, when we have to do this is, suppose, let's say a patient is coming to you with dyspnea. He's having reduced exercise tolerance. He's not able to walk a lot of distance. He's getting breathless after walking 1 minute. But then when you do his echo, it's normal. When you do his PFT, it's normal. At this point of time, you need to do a CPET because that will help you to look at any chronic lung disease. So are there any risks involved in pulmonary function tests? So there are a few risks that are involved. Sometimes during the test, the patient may become dizzy. It's very difficult to keep blowing a lot of air into the machine again and again. So they may get tired. They may start feeling short of breath. They can start having coughing. Patients with asthma can have an asthma attack because of the deep inhalation. So these are some of the things that we need to keep in mind. Are there any contraindications to performing the PFT? So there are a few contraindications. Let's say a patient has had a heart attack within the last 1 month. Better to avoid doing a PFT because the patient has to blow very hard into the, into the machine. It might be a little risky. Suppose a patient is having unstable angina, please don't do a PFT at that time. A patient has undergone a recent thoracosurgery, abdominal surgery, or an eye surgery, let's say a cataract operation or something like that. Then it's better not to do a PFT acutely. Maybe once the patient has recovered, then you can definitely do it. Or if the patient is having pneumothorax right now, already the patient is having a lot of air which is stuck in the lungs. If you make him do a PFT at that time, you're actually giving him more air which goes inside, but then there's no way for him to bring it out. So that increases his restlessness and his breathlessness. So you have to be a little careful when you're dealing with these all situations. So what are some things that you can tell your patients before they go for a PFT? So let's say you have asked your patient to get a PFT done. They'll ask you, doctor, what should I do? Is there any precautions that I need to take? And should I be on fasting? Should I do this? Should I do that? So certain things that you can tell them is don't have a very heavy meal before your test and avoid having drinks or caffeine, and don't smoke or do very heavy exercise at least 6 hours before the test is one thing that we can tell. And ask them to wear loose and comfortable clothing because they'll have to blow in and blow out a lot. And if at all they are using dentures, tell them to keep them on during the test because that will help them to form a tight seal around the mouth. If they remove the dentures, then there'll be a lot of air leak that will happen when they're doing the test. So if a patient is having dentures, kindly ask them to keep them on. So yeah, I think this was in a nutshell about pulmonary function tests. Thank you all.